Thank you very much for the introduction. It's a great pleasure to be opening these presentations today. As my very long title suggests, I will be talking about pediatric brain tumor research and looking at this from a computational angle. So I will be introducing two different types of computational tools that we use in order to provide more personalized and predictive outcomes for these patients. Why do we want to look into pediatric brain tumors? I think it is very much aware that, of course, pediatric cancers are a strong burden on the healthcare system. They are rare tumors. However, the long-term implications for these diseases are, of course, very severe, and a lot of child-related deaths from oncology are actually stemming from pediatric brain tumors. During my project, I'm specifically looking into one particular type of pediatric brain tumor, which is the so-called diffuse midline glioma. It is a tumor of the brain stem, and just one of the very many varieties of brain tumors that are present in the landscape of pediatric brain tumors. Diffuse midline glioma really stands out with particularly poor prognosis for these patients due to the biological nature of these tumors, which is an infiltrative disease, meaning that it is very hard to treat this with localized treatments, and due to the anatomical location of this tumor in the brainstem, which is one of the most sensitive parts of the brain, controlling really vital functions, surgical resection is also infeasible. So what this means is that in order to really maximize the benefit for these patients from our current treatment protocols, it is important that we look at the individual. How is this child going to respond to our treatment? And how can we use potentially also synthetic controls, so simulations, in order to assess if there's even also a small benefit of a new treatment that we are investigating. So what is happening, or where am I with this project in the overall process of a child that is diagnosed with a brain tumor? First of all, of course, the child is presenting to the clinic with symptoms, and we will hear later also in the presentation from Anna maybe more about this. Usually diagnosis in the pediatric brain tumor realm is based on imaging data. Here we're using non-ionizing radiation, so for example, magnetic resonance imaging. That provides very good soft tissue contrast and also really insight into the brain anatomy. Based on this imaging of the tumor, then ideally a team of doctors comes together to make a decision regarding the diagnosis and the treatment for this child. And the treatment is then delivered, the cycle continues. We will use imaging to monitor the success of this treatment and also to identify when resistance sets on so that we make a decision regarding a change of our treatment. So very much this is really a reactive approach. So we observe what is happening and then react afterwards. And imaging is really a cornerstone of this progressive pipeline of our patients. Imaging is not only used to monitor, but also to make treatment decisions, for example, for radiotherapy. Radiotherapy really is one of the key treatments that we're using specifically for pediatric diffuse midline glioma patients. And for this treatment to be most effective, we have to identify the area that we want to expose to the radiation. For this, also imaging is particularly important because we need to define this target region. However, as I mentioned, it is an infiltrative disease, meaning that we will have progression not only specifically where we currently see tumor already on imaging, but potentially also in the close proximity very soon after. So if we could have accurate predictive models of not only the overall volume, but also the anatomical location of tumor growth, we could use this information in order to tailor our treatments, specifically the radiotherapy treatment protocols, in order to adapt these at a personalized level for each child. And the second objective is also to look into the synthetic controls that I mentioned in the beginning, where we want to use simulations to guide how the patient would have looked like under a standard of care if we have an investigative treatment happening. What am I using for this? You saw already in the title, I'm using two different types of computational approaches. Traditional mathematical modeling based on differential equations, but also data science approaches. So this is the AI world, where we're using really highly parameterized approaches to draw a connection between our input data, for example, the image, and our outcome, for example, the response to radiotherapy. Why I'm using both of these is because we are here in a very specific setting. Pediatric brain tumors is a rare disease, meaning that usually the data that we have available is limited. And as you may all know, for data science approaches, the amount of data and the quality of it is really feasible, or is really driving the feasibility of these approaches. So what we are doing here is now to use these mathematical approaches where we're incorporating our prior knowledge into building a system of equation that describes, for example, tumor growth, that can live with a lot less parameters and hence less but much more specific data, and combine this with the data science model that is really flexible to explore connections in the absence of understanding, but relies on more high-dimensional data. So this brings me to the aims of my project overall, and also what I would like to show you today. I really have three folds of aims, which is first of all to quantify response. I mentioned a lot that this will be based on imaging, but I will show you what the current clinical standard is and how we think we can actually improve on that. And then the last two goals is really on harnessing this information that we get from our multimodal imaging, not only to predict personalized outcomes, but also to look at the longitudinal trajectories of the individual patients and their anatomical tumor growth. With this, I would like to now give you an insight into two more deeper projects that I have been looking into. The first one is a collaboration with the Yale School of Medicine, Professor Mariam Aboian, where we looked into longitudinal tumor growth modeling for response assessment. And this comes back to where I mentioned, how are we currently diagnosing or assessing response to a specific treatment that we give to our children in the clinical setting. This is based on the so-called response assessment in pediatric neuro-oncology, or short RAPNO criteria, which is a set of criteria that is applied to imaging data. Here I'm showing you magnetic resonance images of different contrasts, where you see a patient and a tumor. And in the middle, you can see how these RAPNO criteria are currently played out. Specifically, it is actually a bidirectional measurement of the maximum tumor diameter in a plane. So it is a two-dimensional measurement. It does not actually, in clinical practice, account for the whole volumetric changes that we observe. And importantly is also the time factor. If we now want to compare how does this patient respond, based on RAPNO, this is a two-point comparison. We have our baseline image, the reference image, and we have the current image, and we compare these two bidirectional measurements. And I hope it is very clear that even though this concept is very successful in clinical practice, that there are some limitations to it in terms of what, from a scientific perspective, we could potentially do. There's a lack of longitudinal information that is incorporated here with just doing these two time point comparisons. And there is also a lack of volumetric assessment. We're just using these two bidirectional measurements. And so what we did here in this study was actually to use patient longitudinal imaging information, here for pediatric low-grade glioma patients, which were treated as part of two clinical trials. We had two clinical fellows who actually segmented all of these tumors, so we had longitudinal volumetric information for them available. And then we used a combination of mathematical modeling and statistics in order to assess the impact of these two different aspects, so the longitudinal character and the volumetric aspect. And I specifically am looking into the modeling of longitudinal response. This is a very complex slide, I think, but I still wanted to show a little bit some parts of this model that we're using. This is a schematic outlining you, first of all, how usually a treatment response trajectory looks like. This is actually always quite a universal curve. We have an initial response, ideally, followed by onset of resistance to this treatment, which means the tumor progresses again. You can see that I did not put a scale on the time axis, and that is because each tumor, of course, individually responds as a function of time. So it could be that you observe hardly any response. It could also be that this time is such a long scale that, for example, you never observe the progression. It is just about the capability of this model to describe all of these behaviors. And actually, what is showing you now here in these equations is the function of the tumor volume as a function of time, governed by a handful, so actually just two patient-specific and the number of population-specific parameters that control, first of all, the response to the treatment, that is this gamma naught parameter, and the onset of treatment resistance. This is this epsilon parameter. I think it's just important to remember these two are the key parameters. But with these two patient-specific parameters in the growth rate, we can then actually calculate this trajectory for each of our patients, meaning that we get a minimum volume and a time when this minimum volume is reached. Based on this, we can then also categorize our patient. If we are in the time frame before the minimum volume, this patient is responding. If you're just around it, it is stable disease. And if we are beyond it, then it is progressing, which again reflects also the criteria we have currently in clinical practice. And does this work? And the answer is yes. Actually, it worked quite well. I'm showing you here now two examples of two very different patient trajectories, characterized and parameterized by exactly the same model with just slightly different patient-specific parameters. We ran this on a whole cohort of patients and then also extracted the individual parameters for each of them. And then we assessed, is there a difference, a significant difference potentially between the groups of patients that responded to this treatment, which was here a targeted therapy, and those which didn't. Actually, we saw that this parameter which controls for the onset of treatment resistance, that was this epsilon, was significantly different between these populations. So potentially this is driving why these trajectories look different. So it was not only to describe, so this is now really very much we could show that we can very well parameterize the longitudinal behavior. But what is also important is can we actually predict with this as well? And this is what I'm showing you here. So the crosses are data points which we did not consider for the fitting of this model. So they are actually validation, if you want to say. This is what our model would have predicted and what was actually assessed as shown in the cross. And you can see in these two examples, actually it did also quite well for a limited time frame prediction horizon to draw these predictions. And in a very complicated plot on the left side, I'm actually showing you a variety of combinations of how many data points are used for the initial fit, because that, of course, the more data you have, the better your fit will be, or the time frame of the data that is used for fitting, 6 months or up to 1 year data. And as expected, of course, the more data you use or the longer the time frame, the better your prediction. But what I would like you to take away is, first of all, we have this 20% deviation that is kind of acceptable. Clinically, progression or response are assessed within these intervals of 20%. And what you can see is, first of all, that this model is also rather conservative. So if anything, we would predict progression earlier rather than it is occurring. But also to see that I think within the first imaging follow-up, we actually do a pretty good job with this model as well. So what else can we do with this? Not only describe and predict, but we can also quantify now response to progression and response to treatment. And this is what I'm showing you here in one of these trajectories, where we can now, for example, annotate each part of the trajectory with a different color, depending on if this is responding, stable, or progressive disease. And again, this cannot be limited to the volumetric data, which is shown on the right, but could also be done on the 2D data, and we can compare this again. What we did as well is then to quantify how is this assessment, which I'm showing you here, comparing to the clinical gold standard. And for this, we use the so-called BT-RADS assessment. Long story short, it is a more in-depth assessment of the image. It also looks at contrast in addition to just volumetric assessments. And what we found is actually that this model provides a very good both specificity and sensitivity compared to this gold standard assessment. So effectively, we have achieved our goal here in terms of providing the information of the longitudinal context that we would like to provide. And we could also show that we potentially could detect earlier than with the current Wapner criteria if a patient will no longer respond to this treatment. And this brings me now to the second part of my project, which is also looking at anatomical predictions of tumor growth. For this, I'm using generative AI models based on magnetic resonance imaging. And I would like to stress that this is a project I'm doing together with Daria. So she did her master thesis on this, Daria Laszlo, and is also continuing to work on this with me now. What are these diffusion models? Actually, it is just a process that learns to generate an image. And because we have noise in the naming, of course, already, this is based on learning a noising process, and actually the model learns how to remove this noise. So what we do is that we gradually add noise to our starting image until there is nothing visible or hardly anything left of the original image, as you can see here. And then we reverse this diffusion process, so we train a model in order to learn how we can remove that noise iteratively again in order to recover our original output. This is a very compressed version of how diffusion models work, But what we actually want to do is not only to regenerate the original image, but we would of course like to know how does this image look like if the tumor has changed in size. And for this we use a slightly changed, altered version of these denoising diffusion models, and specifically here we're talking about guiding the denoising process in a specific direction. So what we do here is that we inject actually a gradient from a classifier or a regressor that is looking at the specific tumor size that we have, and we can use this in order to guide the denoising specifically in the direction that we desire. For example, here I'm saying, please guide me in the direction of a tumor that is 20% increased in size. And this is not just our own work. Actually, we have Julia also in the audience who laid the foundation for this. So we used an approach that has previously been published and now wanted to see how does this actually apply to our pediatric population, and then also to go a step further, not only to demonstrate that we can grow tumors, but how realistic are these actually. So the aims of this study was really to quantify the realism of these images and to quantify how well does it agree with the longitudinal growth that we observe in our patients. And for that, of course, we need data. This study was predominantly based on a public database, so that is the Brain Tumor Segmentation Challenge from 2023, where we have actually over 1,000 individual images from adults, so adult brain tumor data, glioblastoma, astrocytoma data, and we also have a smaller subset of around 140 patients with pediatric DMG and astrocytoma. On top of that, we then have our own cohort. In this study that I'm showing today, we're actually only using 5 of these patients where we have longitudinal information available that we can then use for validation. Importantly is also that I wanted to show you here the histograms of the image slice location. This is important because adult glioblastoma and astrocytoma are actually hemispheric tumors, whereas I mentioned in the very beginning, if you remember, diffuse midline glioma is predominantly located in the brainstem. And that you can see kind of that you have a larger fraction of tumors here in the lower slices, which was something that we were not sure if this would actually work, if we have potentially this comparison between hemispheric and brainstem tumors. So what we did is first of all to generate some images. So let's have a look, how does this overall work? I'm showing you here results first of all for the adult cohort and then also for the pediatric population on the right-hand side. And actually we trained this on multi-contrast, so T1, T2, T2 flare images, but also on single contrast, because for a lot of our real-world patients, we do not always have this many contrasts available. So this was an important thing that we also wanted to validate. And I think it is maybe a little bit difficult sometimes to see on the images themselves, but if you look at the difference maps, you can actually see nicely that we do increase the tumor size. So here we wanted to achieve a 25% increase, and that what is most important, that it is in an anatomically relevant location. It is in the proximity of the tumor. It does not grow, for example, into the ventricles. So it also preserves the anatomical hallmarks of how these tumors generally grow. So we are trying to abstract here the overall growth patterns of these types of brain tumors. What is, however, very nice about the nature of these models is that they are stochastic, meaning that we can repeat the image generation process many, many times in order not only to obtain a single image, but actually to obtain a growth probability map. So where is the tumor most likely to grow into? And this is what I'm showing you here. So you have these heat maps where you can see the regions of the brain which are at most highest risk, based on this model, to have this tumor progression. This was all nice, so it looked good at a first sight, but what are the numbers? So how good does this actually perform? And so for this, we used actually 2 quantification metrics. We used the so-called FID metric. This measures the distance between image distributions, between real images and the images that we have generated. And we also looked at structural similarity between true and generated images. These are 2 metrics. Long story short, we would like the FID to be low and the structural similarity to be close to 1. The FID, however, I should stress, is very much dependent on the dataset size. So we would expect a less favorable outcome for our pediatric population, which is also what we observed. But for the structural similarity, I think it is very nice to see that overall this looks actually pretty good. And also in terms of the FIDs, around 20 is actually something that is pretty good in terms of what other similar models are achieving on medical imaging data. Of course, not on pediatric brain tumors specifically, because this has not been done before. But what we really wanted to know is not only in terms of numbers, how do these images look like? Are these realistic? And one of the tests we did is actually that we gave these images to our trainees, so radiologist trainees, which are used to looking at images of pediatric brain tumors, and we asked them, can you tell me, is this a real image or is this a generated one? And we had 2 observers, so this is still a preliminary result, but actually it was really nice for us to see that they were not able to differentiate these at all. I think they were a bit disappointed once they received these results, so we were actually really happy. And I mean, maybe you can also have a look yourself to think if you would have been able to guess that actually the bottom left and the top right are generated images. We're also continuing here now to look into this further with radiomic features and quantifying these so that we can also go down into how realistic are these images, looking for an algorithm that would process them. But of course, what is ultimately important is the longitudinal validation. And for this, I'm showing you here one example of one of our DMG tumors from the DMG Center in Zurich with their growth trajectories. So here we have 4 imaging time points. You can see below here these 4 images of this particular patient. And you can see the first kind of significant growth happened between the imaging time point at 9 and 25 weeks. And then the growth really increased a lot until the next imaging time point. And at the top, you can then see the generated tumor growth probability maps for these particular images. And even though, I mean, there are still, this is work in progress, so there's still a lot we want to improve on this, but what we could recapitulate is the overall direction of the growth and also the overall extent to some degree. So I think especially for this example here, it worked actually quite well. We had a good agreement between the expected and the actually observed location of the tumor. And for the second example, that's why I also wanted to show this here, there was maybe a lot more growth than we would have initially expected. And you can already see that there was some discrepancy also in terms of tumor volume. And I would like to stress that this is likely due to the extent of the growth. So this tumor grew significantly, so almost tripled in terms of the area that we observe on this image. And it was potentially going beyond what we trained. We were always aiming around 25%, which is the clinically relevant cutoffs. But still, if we take all of these scans together, and it's so far only 5 patients, and we calculate the dissimilarity coefficient, we actually obtained very favorable results overall on the order of 0.8. So with this, that brings me now to the conclusion of my presentation. I hope I could show you how important imaging is. It is really a cornerstone of the diagnosis and the monitoring of pediatric brain tumor patients. And specifically here, we're looking into providing personalized predictions in terms of longitudinal response and anatomical response, using here diffusion models in order to generate these anatomical representations, which are currently providing us very promising initial results, especially in terms of these tumor growth probability maps that we can use here. Of course, this is an ongoing project, and we're currently actively working on much more longitudinal validation data being generated. And I did want to give a shout out to my team who are working very hard with me together to curate manually over 1,000 individual images, so that then we can actually combine these 2 approaches, which I showed you today. So the mathematical model to predict the size of the tumor with the diffusion model in order to then guide the anatomical prediction to the size that we have predicted. With this, I would like to thank you for your attention, the BRCCH for their support, and all of my collaborators who are actually supporting me as part of this project. Thank you very much.